Okay, good afternoon, everybody. Thanks for the kind introduction, and thanks very much to VAADA for inviting me to speak here today, even though you gave me the graveyard shift. Thanks to everybody for sticking around. So we're nearly there. It's been a wonderful 2 days, and thanks everybody for sticking around to the very last presentation. So I'm going to be talking to you about novel psychoactive substances today, or NPS. Some of you might be very familiar with these substances, some of you might not be so familiar, but I'm hoping to give you a bit of an overview today. So I'd just like to start by acknowledging the traditional owners on the land on which we meet here today and paying my respects to elders past, present and emerging. So we know that drug deaths in Australia are a big problem. The number of drug-induced deaths first took over the road toll back in 2007, and the gap has continued to widen since then. We now have a fatal overdose every 4 hours in Australia, and there have been over 42,000 drug deaths in Australia since 2001. Now, these are mostly unintentional and mostly preventable. Now, this increase in drug-related deaths has really been disproportionate to the growth in the Australian population. And we have seen particular trends in different states according to the different illicit drugs that are responsible for some of these deaths. So in Victoria, as you can see, stimulants are a particularly big problem, second only to WA. We know from the recent drug strategy household survey that around half of Australians have used an illicit drug in their lifetime. So this is a huge proportion of the community who are at risk of illicit drug-related harms. Of these illicit substances are the new or novel psychoactive substances, or NPS. You can see here, this is why we're so concerned about these substances. The number of drug-induced deaths in Victoria involving these NPS has increased by about 2,000% since 2018. Now you can see on the left some of these different types of NPS subgroups. These are really synthetic substances that are designed to mimic the effects of mostly illicit substances that have really taken off around the world and have become a global problem over the last couple of decades. So they're also known as legal highs, designer drugs, herbal highs, bath salts, spice, some of these names. Many of them were first designed in the 1950s or even earlier as alternatives to other pharmaceuticals. In many cases, the development of these drugs was abandoned because they were considered to be too toxic or potentially addictive. Like I said, they mimic the effects of a lot of drugs, including some of the pharmaceutical substances that are available around the world. And they're often produced by introducing slight modifications to the chemical structure of some of the controlled substances. And this has been done for many years to evade law enforcement. They've got very complicated pharmacology and toxicology, and many of these drugs we still really don't know a lot about, especially since they're constantly emerging in the global market. Up until the end of last year, there'd been over 1,200 different NPS reported to the United Nations Office of Drugs and Crime. You can see here there's a big spread across the whole world of these substances. There's really no continent that misses out on these NPS somewhere across the continent. There are some places like North America and Europe where we're seeing higher reports of these substances, but a lot of this also comes down to the reporting systems in the different countries. One of the reasons that these drugs are spreading around so quickly is because of how easily they're trafficked around the world. So many of these drugs are really potent in really low doses, which means that the quantities that need to be sent around are much, much smaller. So you're not having to post 50 kilos or traffic 50 kilos of heroin across the border when you could instead just send a matchbox size amount of nitazenes. A lot of them are being purchased on the dark web, and you can see there's even reviews of how effective these drugs are and how good they are. So relatively cheaply purchased online and delivered by Australia Post. So it makes it very easy. You can see here this is European data, so reported to the now called VAADA, the European Union Drug Agency. And you can see here just how much these MPS and the MPS market has really evolved over the last decade or two. So the most commonly reported NPS are the cathinones up in the blue and the cannabinoids. But one of the categories we're really concerned about are the blue ones here, the blue line popping up here and increasing in the last few years, which is the synthetic opioids. Now, this is the United Nations Office of Drugs and Crime, or UNODC, Early Warning Advisory Tox Portal. And this is really useful. It's a public dashboard that you can get information about all of the different MPS that are being reported in different regions of the world. So this one is just the Oceania region. Now, of course, this depends again on the reporting of these MPS from these different regions. Currently, it's mostly Australia and New Zealand reporting the MPS in this part of the world, but we're still working with the UNODC to try and increase the systematic reporting and sort of more comprehensive reporting of MPS in this part of the world. But you can see that the distribution of the different MPS really indicates a strong prevalence of the synthetic stimulants in this part of the world, followed by the synthetic cannabinoid receptor agonists. So the drugs designed to mimic the traditional illicit stimulants and cannabinoids. We've also got classic hallucinogens, which are very popular in this part of the world. What's interesting, even though we've got over 1,200 different MPS reported to the UNODC by the end of last year, the number of new NPS being reported has actually declined in recent years. Looking at our border seizures around Australia, the number of MPS border seizures actually doubled in the reports from the ACIC between 2020 and 2021. And like I said, these drugs are really typically transported by international mail, which makes it much harder for border control to actually intercept these parcels. Of the total analysed seizures of NPS reported in 2021, most of these drugs were some of these stimulant-type drugs. The other NPS category included the 2C group substances, synthetic opioids and ketamine analogues in about 40%, and then the cathinones as well. So we're seeing increasing quantities of these seized. Now, this is some data that's quite interesting from the EDRS, the Ecstasy and Related Drugs Reporting System. And you can see here that there's actually a decline in people reporting the use of MPS. It's really been on the steady decline since 2013, with only 11% of participants reporting the use of any MPS in 2023. But what's important to note about this is the adulteration of the illicit drug market. And this is where we're typically seeing the MPS pop up. So a lot of people are not expecting to be using these MPS and not unknowingly being exposed to this higher risk of harm because of the adulteration in the unregulated drug market. So this is a paper by Monica Barrett and her team that found that looking at analysis of the substances sold on a particular crypto market called Test for Pay, only 65% actually contained the advertised substance, 14% contained an additional psychoactive drug, and in 21% the advertised substance was absent altogether. And this is what we're seeing in a lot of our clinical and forensic casework as well, that there's a lot of adulteration going on in the unregulated drug market, and this is becoming an increasing problem with NPS, particularly because they're so potent. Now, like I said, the NPS group really of most concern, and I'm sure a lot of you have heard a lot about these over the past year or so, is the emergence of the potent synthetic opioids or novel synthetic opioids. So you can see here, and this is again data from Europe, that, too early. We'll leave that one up there. It was really the fentanyl type analogues that were around from around 2012 and really peaked in 2017. And then started dropping off. And it wasn't until 2019 that we started seeing these benzimidazole opioids, or the nitazenes more specifically, start to emerge on the synthetic drug market. The little figure up in the top left-hand corner is data from the US, and you can see that that's really consistent as well. So in 2018 and 2019, it was mainly the fentanyl analogues that they were seeing detected around the country. Isotoniazine popped up in 2019, and this was really the emergence of nitazenes in the global market. Later that year it was scheduled. Nitazene popped up in 2020, and by 2021, the novel synthetic opioid market was completely dominated by nitazenes. So this is what we've seen consistent with other countries around the world. Now, why are we seeing these potent synthetic opioids? We don't really know why they've suddenly started popping up, but one of the reasons could be behind some of the global changes in drug supply. So we know that in 2022, the Taliban banned poppy cultivation, and we know that Afghanistan supplies 95% of the UK and Europe's heroin. By the following year, the poppy cultivation reduced by 95%. So you can see here on the left, the pink indicates the poppy cultivation in 2022, and by 2023, it was almost completely gone. So this means that there's going to be a dry up in the supply of the heroin market, could be in the next year, could be sooner, could be later. But the illicit drug market is extremely resilient. And as we heard from James about his talk yesterday, they will fill that gap. And that's what we're concerned about with these potent synthetic opioids, that they will really start to increase in prevalence as the heroin market slows down. This has also been raised as a concern by the UNODC, who noted that the illegal drug markets are expanding and evolving constantly, particularly because the synthetic drug manufacture is so cheap, it's so easy, and it's so fast. And also because the way that these drugs are manufactured involves precursors, lots of different precursors that can be used, and makes it much more difficult for border control to intercept these precursors at the border, particularly when there's so many different compounds that could be used. So at one point, years ago, they were sort of looking for the chocolate cake coming across the border, but now they're looking for the eggs and the flour and the milk, and it could be any kind of variety of these different products that they're trying to intercept. So it just makes it that much harder. And just to give you an idea of the profit that drug distributors can make from these synthetic drugs. Now, this is actually a comparison between heroin and fentanyl, but keeping in mind that the nitazenes are actually even more potent than fentanyl, some of them are at least, it just gives you a bit of an idea of the profit that some of these drug distributors can make and that incentive behind the use of synthetic drugs in the illicit drug market. So if you bought $1,000 worth of product and chopped it up for retail sale, with heroin purchased in Mississippi in the US, you can make a profit of $4,000 US. And with fentanyl purchased from China, you can make a profit of up to $8 million US. And when you're thinking about nitazenes that are even more potent, you can just see how much profit can be made. So moving on to nitazenes, and some of you came to Susie's talk earlier today and got a very good overview of the pharmacology of these drugs. They were first synthesised in the 1950s. It's an alternative to morphine, but the development of them was stopped because they were found to be highly toxic and potentially addictive. So they re-emerged in Europe and the US in 2019, and by 2023 there were 13 different nitazenes reported to the UNODC that they were monitoring. You can see here a lot of them are coming out of China, which has one of the biggest chemical and pharmaceutical industries in the world. But we've also seen some of the cargo ships carrying nitazenes come across from the UK, so they're moving all the way around the world. I won't go into too much detail on the pharmacology, but just to say that they're very potent mu opioid receptor agonists. They have heroin-like effects, including that dose-dependent respiratory depression, but typically much more profound respiratory depression with much faster onset. They're also fat-loving drugs, which means that they're really rapidly uptake into the brain, so they have a very fast onset of action compared with some of the traditional opiates like morphine. Now, the potency of nitazenes really varies. So some of them can be quite similar to morphine, and others are many times stronger than heroin or even fentanyl. There's lots of different studies on the potency of nitazenes, and it really just depends on the assay that's been studied. But you can see here, this is a recent publication from The Lancet that showed drugs like protonitazene, which is the most common nitazene we're seeing in our clinical and forensic casework at the moment. It's about 100 times more potent than heroin. And then you've got other products, other compounds like etonitazene, which could be up to 500 times more potent. So we're seeing these drugs in all different forms. We're seeing them as powders, as crystalline solids, as liquids. in counterfeit opioid tablets, and it's the counterfeit oxycodone that's been really driving the nitazene deaths over in the UK. But we've also seen them here in Australia in substances sold as heroin, ketamine, ecstasy, and even synthetic cannabinoids. So you can see the risk of unintentional exposure to these drugs, not just for people who are used to taking heroin and have that opioid dependence, but for even more of a risk for people who don't have that opioid tolerance, who perhaps aren't carrying naloxone, to be exposed to one of these nitazenes unintentionally is extremely dangerous. So they can be injected, inhaled, or swallowed. There is some evidence that people are actively seeking nitazenes across the world for their opioid effects, but on the whole, the majority of exposures appear to be unintentional. Again, I won't go into too much detail on the pharmacology, but just to say that the particular preferential activation of the beta-arrestin pathways that some of these nitazenes have mean that they produce a much more profound respiratory depression compared with heroin. And obviously the use of other central nervous system depressants like benzodiazepines or alcohol can really exacerbate that overdose risk. The really concerning thing about these drugs is the window of opportunity to intervene in an overdose is much smaller. So it might be around 25 minutes for a heroin overdose, but for a nitazene overdose, it could be as little as 2 or 3 minutes. So without rapid medical intervention and administration of naloxone, there's a really high risk of overdose and death. One of the really concerning things is the really significant at-risk population in Australia. So as we've heard earlier today in the conference, we know that 1 million Australians have used cocaine in the last year. 400,000 Australians have used MDMA. And around 1 million Australians have also reported recent non-medical pharmaceutical use. And this is really concerning because we've seen nitazenes pop up in all of these different drugs around Australia. This is something we've been monitoring in our clinical and forensic casework, and it just demonstrates how many people are actually at risk if there's a surge of potent synthetic opioids in the unregulated drug market. So looking at the situation around the world, we have seen increasing border seizures of nitazenes here in Australia. Many of them have actually been coming, like I said, from the UK in cargo mail. So there's a lot coming just in the post from China and India as well. But 22 seizures reported from the Australian Federal Police towards the end of 2023, containing over 800 different nitazene tablets, actually came from the UK. Last July, there was a 4-kilo seizure in Melbourne. So considering how potent these drugs are, that's really enough to change the market and cause thousands of deaths if it actually got onto the street. I'm sure many of you are aware of the cluster of 20 overdoses over Easter weekend last year in New South Wales for nitazenes in what was sold as heroin. And we now know that there's been 22 deaths reported to the coroner here in Victoria, which I'll talk about a bit more in a minute. So you can see there on the little table down in the corner that we've seen nitazenes detected in almost all states around Australia. Throughout the world, they're also causing significant concern. So they're reporting about 2 deaths a week in the UK from nitazenes. A recent report from the UK government has reported that there's been over 400 deaths in the UK involving nitazenes since June 2023. And as Susie spoke about earlier today, many of you would be aware of the Dublin clusters of overdoses involving nitazenes in late 2023, which I'll talk a bit about as well. In Eastern Europe, they've become an increasing problem. So they've been detected in nearly half of the drug deaths in Estonia and in about a third of drug deaths in Latvia. In America, it's really hard to say. They've got such a big opioid epidemic over there. The testing on post-mortem cases is not as extensive and systematic as we have here in Australia, but they estimate there's been at least 2,000 deaths across the country involving nitazenes. But really, there's still a lot of information we don't know about these drugs, particularly because they're so new on the illicit drug market. So one of the ways that we're monitoring these emerging substances is through the Emerging Drugs Network of Australia, or EDNA project. Many of you here are involved in the EDNAV project, EDNA Victoria. So I'm just going to present a bit of data on this project today. So EDNA is a multi-centre toxico-surveillance system that's really focused on identifying and monitoring both illicit and emerging drug-related presentations in a number of our sentinel emergency departments across Australia. So you can see we've got 6 different states and territories involved in the project that are contributing data to our national data set. So basically the way it works is when a patient presents to one of our sentinel hospitals with reported or illicit drug toxicity, there's a lot of clinical information that's collected by the site investigator, so including the triage information, the reported drug exposure by the patient or the witnesses, the clinical findings, the management and outcome of that patient. And then what's the important part of this project is we take their blood sample and send it to the respective forensic laboratory of the state for a really comprehensive toxicological analysis, including a wide range of MPS. So we're looking at sort of over 2,000 different novel compounds that we'll be able to detect. So this is the EDNA dashboard as of this week. You can see there we've got over 4,200 cases across the country. Most of the presentations are young males in their early 30s. And I think it's important to note that the majority of cases, 40% of our cases, are occurring in the patient's residence and then they're being brought into the hospital. So it just really highlights the importance of all of the harm reduction approaches that we have for people using drugs in the home. So you can see here on the left is the 15 most frequently occurring illicit drugs, and I'm sure it wouldn't surprise any of you that methamphetamine tops the list, followed by GHB. But you can see bromozolam, which is one of the novel benzodiazepines, is still one of the most commonly detected drugs, up at 4th on the list of all of the different substances that we detect. When we look at the MPS specifically, bromozolam tops the list, and I'm going to talk a bit about novel benzos in a minute. You can see that 415 of our total sort of 4,200 cases involve MPS, many of them co-detected with other illicit drugs, particularly methamphetamine and GHB. And the median age, although they're still male, is a little bit younger than our overall cohort. The nitazene that's most commonly detected is protonitazene. It comes further down the list there under a lot of the novel benzodiazepines and some of the novel stimulants. But when we look at the ICU cases, protonitazene is much higher in the list. So we get an idea of the potency of some of these compounds depending on where we're seeing them turn up in our EDNA data set. Now, looking at the MPS detections over time, this is for our 2023 and 2022 and 2023 data from EDNA, combining the EDNAV data set. So each state has their own sort of in-house data set, but EDNAV has a lot more cases than EDNA nationally, and we don't contribute all of our EDNAV cases to the EDNA data set. So sometimes we complement the EDNA data with some additional cases from EDNAV. So you can see there the sedative hypnotics or the benzodiazepines mainly are all of these blue lines here. The stimulants in the green, synthetic cathinones, I'm not really going to talk about those today because although they're a commonly reported MPS, we just don't see a lot of them in our clinical and forensic casework. And the red is the opioids, with a few more popping up at the end of December. So these are the main groups that I'm going to spend a bit more time talking about today. These are the MPS groups that we're seeing a lot more of in the community. You can see here on the left the benzodiazepines with bromozolam topping the list, followed by clonazepam and clobromozolam. So designer benzodiazepines, or novel new benzodiazepines, whatever you want to call them, these are the most common of all the MPS types that we're seeing, not just here in Australia, but globally as well. And what's interesting is even though we're all obviously geographically, very geographically isolated here on an island in the middle of the ocean, but we still see the same MPS popping up in different countries in the same sort of frequency and prevalence. So designer benzodiazepines, obviously drugs designed to mimic the effects of pharmaceutical benzodiazepines. The European Union of Drug Agency, or EUDA, is currently monitoring 33 different new benzodiazepines, and a lot of them are actually being sold as counterfeit products. So you can see here this counterfeit Karma sold on the right, and how similar it is to the actual real deal. So it's a particular concern for people in the community thinking that they're getting diverted pharmaceuticals when they're actually getting counterfeit products with very unethically manufactured NPS. You can see here the evolution of the novel benzodiazepine market. Started seeing them pop up in 2007, but we've seen the majority of the different novel benzos since 2015. So like a lot of the other NPS groups, they have different potencies, different half-lives. A lot of the pharmacology we still don't know a lot about, but typically, like the pharmaceutical benzodiazepines, they're used for the same sort of anxiolytic and sedative effects. Some of them have different effects to the other NPS benzos, like the induction of euphoria with flubromazolam. So they may be licitly prescribed in some countries. For example, for Fenazepam, we've seen a bit here in Australia. It's an illicit benzodiazepine, but it's actually a prescription benzodiazepine in Russia. So there are some drugs that are prescribed in Italy or Japan or Siberia that we've detected in our EDNA data set, but they're illegal here or not registered. And they also can be mixed into the illicit drug supply. So you may have heard of benzodope over in the US, where some of these novel benzodiazepines are being mixed into the fentanyl supply. So this is a very busy slide, but just to say this is some of the data from the EDNAV project, so our Victorian specific project, and it just shows the unpredictability of the novel benzodiazepine market. You can see down here, these are all the different novel benzodiazepines we've detected, and this is in a paper that we published looking at data up to the end of 2022. Some of the drugs we're seeing across the entire study period, like clonazepam, others pop up and disappear. It's really hard to know what we're going to see next with these novel drugs, not just the benzodiazepines. The novel benzos we're detecting in the majority of our NPS cases in EDNA and in EDNAV. So in 16% of our EDNAV cohort, we see at least one novel benzodiazepine, which is a lot considering we're looking for illicit drug presentations overall. The median age is quite a lot younger, so 24 years, but the majority are male. We actually are the only state that are able to collect cases of patients as young as 12 here in Victoria. All the other states have a limit of 16 years, and that's because early on in the study we found that there were lots of reports from some of the site investigators at the different hospitals that there were lots of younger people coming in with reporting novel benzodiazepine use and presenting to hospital emergency departments with toxicity. So it was something that we wanted to continue monitoring, and we've seen a much younger age group of people exposed to novel benzos. This is something we've also seen in the Victorian overdose deaths data. So you can see here, this is the data from 2014 to 2023, and the novel benzodiazepines there in the blue line, the most commonly contributing drugs or NPS to coroners' cases. So over 40% had more than 2 novel benzodiazepines detected in our casework, and typically it was only a single substance consumption. So a lot of the people who had died had, according to witness reports, they had consumed only a single tablet, and this is something we saw with some of the EDNAV cases as well, that had multiple different novel benzodiazepines within that one substance. So some of the EDNAV cases we had that presented to our emergency departments with benzodiazepine toxicity had used just a single tablet with up to 5 different novel benzodiazepines in that one tablet. So you get an idea of just how toxic these are, particularly in combination. What's interesting is looking at the transiency and the change of the novel benzodiazepine market here in Victoria based on the data we're seeing. So between 2015 and 2020, it was atizolam that we were seeing across all of our clinical and forensic casework. But then that's sort of supposed to be a little bit further right. But anyway, by about 2020 and 2021, flualprazolam and flubromazolam appeared in our coronial cases with or without atizolam. That should again be a little bit further right, but by 2022, atizolam disappeared altogether, and we started seeing a lot of bromazolam, clobromazolam, and clonazepam. And by 2023, it was just bromazolam that was dominating the MPS detections in our coronial cases. This is a bit of a nicer overview of those deaths, and you can see all the way back from 2015, atizolam there really dominating the MPS market in the beginning, the pop-up of flualprazolam, some other novel benzos, and then it was really bromazolam that has taken off in late 2022 and dominated the market since then. Of the stimulants, we're not really seeing many others aside from N,N-dimethylpentalone. So a lot of these synthetic stimulants we're seeing really co-detected with some of the traditional illicit stimulants, indicating an adulteration of those stimulants in the unregulated drug market. So the novel stimulants are much more common across the globe. UDA's now monitoring over 170 different synthetic cathinones, more specifically, and that's the second biggest group after the synthetic cannabinoids. So you can see here that first popped up on the market in 2015, some of those first generation novel stimulants like methylone, and have changed over time post-2022. We're mostly seeing the N,N-dimethylpentalone around the world. So these are usually, the synthetic cathinones are phenethylamine derivatives of cathinone, which is that principal psychoactive component of cat. They typically have amphetamine-like effects, but they're often with a much higher potency. So we see some much higher, much more exacerbated effects with some of the detection of some of these drugs compared with some of the traditional amphetamine-type substances. So they are similar to some existing stimulants like methylamphetamine, which has raised a lot of concern around countries in the world where methylamphetamine is a big problem, like here in Australia, because there is that potential for fortifying the methylamphetamine in the unregulated drug market, and also for the synthetic stimulants to expand, for the market to expand just for the demand. And like I said, they're really commonly detected as adulterants in traditional stimulants. Now, like I've mentioned, Edna Victoria, or EDNAV, we've got a really wide range, a really broad network across Victoria of different hospitals, which allows us to detect lots of different signals across the state. We've got 17 different hospitals involved in EDNAV at the moment, and many of you here are involved in this project. But what makes us different to other states is our involvement with St John Ambulance. So they came on board as one of our additional sites over the 2022-2023 summer. St John Ambulance provide ad hoc testing, festival testing at multi-day events for the EDNAV project. So I'm just going to talk a little bit about some of that data. So as you might know, St John Ambulance attends and services some of the really high acuity events throughout Victoria. They set up temporary field hospitals with up to 30 different beds, like mini hospitals on site, really. It's very impressive. They have a medical assistant team with at least one critical care physician, like an intensivist or an emergency doctor, that are capable of providing advanced airway management, so the tracheal intubation. So over the 2022-2023 summer, we piloted the EDNAV methodology at 6 different festival events serviced by St John Ambulance. We retrieved 39 blood samples, mostly of young males, which is consistent with the music festival demographic. Most of these patients were presenting with an altered conscious state, agitation, they were seizing or were unconscious. So the majority of cases recovered with supportive care. Some were required sedation and airway support. But what's interesting and important is really the outcomes. So 16 of these cases were transferred to hospital. They're the cases that we would likely see in the EDNAV data. But there were 20 cases that were returned to the festival, either returning to their dancing or back to their campsites, and 3 of them were discharged home. So these 23 cases we would have completely missed from the intelligence in terms of our drug monitoring. So this has provided a really important additional way of monitoring some of these emerging substances in the community by capturing this additional information at music festivals. We've continued this over the 2023-2024 summer, and again this summer as well. This is some of the data from these 6 events, and you can see here the blue is where the drug here, so the MDMA, cocaine, ketamine, where the drug was detected and reported by the patient, and the orange is where we detected that drug but it was not reported by the patient, so unintentional use. Now, some drugs like meth we're seeing detected as either as adulterants, or sometimes we're still detecting methamphetamine from somebody that's used it yesterday or the day before and chose not to report it. But what was really concerning is the MPS that we detected. We detected these drugs in 16 different cases, and only in 1 case did the person say that they'd knowingly used it. So there's the potential exposure to these really harmful synthetic drugs in 15 of these cases, in the majority of the MPS detections, potentially exposing these individuals to a much higher risk of harm. And now moving on to the opioids. So we've heard a lot about these opioids. I'm just going to touch a bit on the EDNA data in particular, because this is something that we need a lot of this new information on these emerging drugs, and it's pretty difficult to get, especially with coronial data, which relies on case closure rates by coroners to be less than 2 years, which makes it very difficult. So the most common nitazene that we're seeing is protonitazene, and that was back in 2022, 2023. We recently conducted a study of nitazene presentations in the EDNA data set across Australia. This was led by Kathy Zawadi up in Queensland. So we looked at cases between 2020 and 2024 last year and found 32 presentations. Most of them were male in their early 30s. 16% intended to use these nitazenes, 38% intended to use another opioid, but nearly 50% of them had no idea that they were actually using an opioid at all. So you can see that really high risk of people who have been unintentionally exposed to not just any opioid, but a very potent synthetic opioid. So you can see here the protonitazene was the most common, followed by metonitazene, and we also saw one of the N-peroladino analogues, which is a very potent compound. We saw co-exposures in nearly all cases. So methamphetamine, not surprisingly, topped the list at over half of the cases. We also saw pharmaceuticals commonly detected in nearly 70% of cases, with most of those involving benzodiazepines. Now, there was a talk yesterday about the combination of prescription and recreational drugs and the additional risk that can carry, particularly if people are not aware of the risks of combining pharmaceutical and recreational drugs. We also saw another MPS in nearly 40% of cases. So not surprisingly, we saw the same sort of effects that we would see with an opioid toxidrome, so pinpoint pupils in around half of the cases, a low respiratory rate, very sedated patients with a Glasgow Coma score of around 3. Naloxone was used in around 3/4 of cases. But what was interesting was that the median dose was only 300 micrograms IV. So in some cases, in 13% of cases, a naloxone infusion was required. But on the whole, regular sort of doses of naloxone or standard doses of naloxone were sufficient for these patients, but some of them required multiple dosing. So some of them required naloxone administration by a peer, then the paramedic, and then in the emergency department. And also, it's important to note that nobody died, which is really good. So we've only got a mortality rate in the EDNAB data set of around about 1% or 2%. So it just shows how really great our medical services are here in Victoria, that if you get to an emergency department in time, then you should be okay. So like I said, standard doses of naloxone really were effective, and these nitazenes really appeared to behave like other short-acting opioids, which is what the international evidence has shown as well. So looking at the coronial data, here you can see that the potent synthetic opioids were the second most frequently contributing NPS category, mostly nitazenes. We first saw isotretinoin in May 2021 and etodesnitazene later that year. Unfortunately, we didn't know about those detections back then because of the limitations of accessing coronial data, and that's what we're working on at the moment to try and speed up some of the release of some of that coroner's casework. In 2022, we actually detected one of the N-proladino analogues, one of the very potent forms. We didn't see protonitazene until later in 2022, and that's been the most common drug since then, and then midonitazene as well, and lots of combinations of protonitazene and midonitazene. So most of our coroner's cases involving nitazenes are between 18 and 50 years old. Most of them involve mixed drug toxicity, many with benzodiazepines. What's interesting is looking at the concentrations of these drugs that we detect, so really low concentrations. And that's one of the analytical challenges with detecting some of these NPS, because they're so potent, well, many of them are, in really low doses, where we struggle to detect the really low concentrations without really advanced instrumentation and methods. But you can see here for some of the drugs like the N-proladino analogue that's much more potent than fentanyl based on some of the assay studies that have been done. We're seeing much lower mean concentrations of only about 0.4 nanogram per mil. Then for some of the nitazenes that are not so potent, like etodesnitazene, we're seeing higher mean concentrations. So keeping in mind this is a lower sample size, but you can see the really low concentrations that we're detecting of these drugs. All of the coroner's cases for nitazenes involved at least 2 other drugs. There were no monointoxications, so potential for much more exacerbated drug toxicity. Mostly stimulants and benzodiazepines. And when we look at these in particular, you can see on the left the stimulants that we detected are a lot of the traditional kind of illicit stimulants, methamphetamine, MDMA, only a couple of cases in synthetic cathinones. But for the novel benzodiazepines, it's primarily novel benzodiazepines that we were seeing combined with nitazenes. So whether they're being co-used or unintentional exposures, we're not sure whether it's mixed in. Now, moving on to our current drug signals here in Victoria. Currently, we've got a number of different sources of different data that we're able to get a lot of really useful information on emerging drugs throughout the state. So there's the RAPID study, which analyses residue analysis of used syringes. We've got EDNAB, which I've spoken about, coronial findings, although it's much harder to get current information on coroner's cases, and then obviously the drug checking service, which really is going to be critical in detecting some of these emerging substances. But often there's a minimum 7 to 10 day delay from when the substance is first used and analysed to when we actually have that result. The Department of Health goes through their risk assessment process, determines whether a response is necessary. Obviously, there's not a response necessary for all drug detections, and then this leads on to a public alert. So this process can take quite some time, and that's why we need to really speed this up for these emerging substances. And this is a very good example of just how necessary it is to rapidly identify some of these drugs in the community. So late in 2023 in Dublin, they had a cluster of nitazene overdoses, but were able to really quickly respond to the identification of these substances in the community. The health executive, basically the Department of Health there in Ireland, were notified of an unusually high pattern of opioid overdoses occurring in the centre of Dublin, particularly among people attending homeless services. These really reflected early changes in the drug market and what was later to be found the emergence of N-pyrrolidino protonitazene, which is a particularly potent nitazene. There were 57 overdoses in 5 days and another cluster of the following month in Cork, which brought the total to around 80 overdoses. But there were really rapid responses implemented that aimed to really protect the people who use drugs in the community. They had really rapid analytical review with their drug checking services. They mobilised the frontline services to really deliver tailored harm reduction advice to the people who use drugs. And they implemented these red alert risk communications. So you can see here on the right, warning signs out on the street, on the traffic signs, warning about the contaminated drug supply. So the takeaways from this example were that, firstly, these substances can emerge without warning, really rapidly hit the unregulated drug market and cause devastation, really, significant overdoses in a really short period of time. And that outbreaks really require not just urgent responses, but preparedness. They responded very quickly to this, but since then, there's been a huge number of different states, counties, cantons around the UK and other parts of Europe and North America that have developed their own preparedness plans for these synthetic opioids. So that brings me on to our plan here in Victoria. In the middle of last year, there was a consensus among sector leaders in the alcohol and other drug space that we really needed to prepare for a surge in potent synthetic opioids in the community. This was particularly evident following the cluster of deaths, those 4 very tragic deaths in Broadmeadows in the middle of last year. And so we got together and formed really an informal network back in July last year to prepare for a surge in these sorts of drugs. We've now got over 25 members representing a really broad range of the sector, which is really important. And although there are similar approaches in other states to identify emerging drugs in the community, what sets us apart in Victoria is the strong representation of harm reduction services and people with lived and living experience. This means that we've got a much better community reach. We're able to identify these substances in the community much more rapidly and disseminate the information out to the community as quickly as we can. One of those people is Craig, who gave a great talk earlier today about SMS alerts, and that's something that's developed in this group as well, as the approach to communicating these messages to the community and how rapidly we could get them out. So the main objectives are to detect and monitor information on potential signals of these potent synthetic opioids and related drugs. Develop protocols and information and dissemination mechanisms, so obviously to get the information out into the community as quickly as possible should a surge occur, and to facilitate rapid and optimal responses to changes in the substance use patterns that we might see and high-risk signals in relation to these synthetic drugs. So Susie mentioned this earlier today, and hopefully this QR code does work, but we have developed an online reporting form to monitor community signals of these potent synthetic opioids. This is for everybody to jump online to, and we really encourage people to advertise this far and wide. Essentially, if anybody experiences or witnesses an unusual overdose, an unexpected drug effect, or an unexpected drug checking result that indicates that we might have potent synthetic opioids in the community, we want to hear about it. After that, we're working with some of our members, especially Richie Goonan and Craig Harvey, who are working to develop individualised service responses to potential outbreaks. So if we do see something, we're prepared and we can respond rapidly. It really is an insurance plan, I guess. We're hoping that we never have to implement any of these approaches. We're hoping that we never have to worry about this, but we want to be sure that if it happens, we are prepared. So we meet fortnightly, we have since July, and we have a WhatsApp group as well to stay informed of any potential signals. Like I said, it's really unique to Australia because of that representation of lived and living experience and harm reduction services. And that really enables us to rapidly reach people who use drugs in the community. So just to summarise my talk, I know you've done extremely well. We're nearly at the end, so thanks for staying with me. The NPS market is really constantly evolving and expanding. We're seeing increasing drug adulteration in the unregulated drug market. And although the substances might be changing, the at-risk population might be changing, what's constant is that expanding and evolving NPS market and the adulteration that we're seeing in the community. There's evidence of it being a really big concern globally with devastating impacts, especially in the UK and North America. And often we're seeing a lot of these drugs, or most commonly we're seeing these drugs as adulterants in illicit substances, which really exposes people to a much higher risk of overdose, higher risk of death, and particularly for a really high at-risk population in Australia, considering how many people use illicit drugs in this country. So it really just highlights the need to be prepared to rapidly respond to these drugs, particularly if there's a sudden surge, and particularly with some of the changes we're seeing in the international drug market. And just wanted to finish with this quote from G.L. Henderson from the Journal of Forensic Sciences back in 1988, so 30-odd years ago. He said, "The future drugs of abuse will be synthetics rather than plant products. They will be synthesised from readily available chemicals, may be derivatives of pharmaceuticals. They will be very potent and they will be marketed very cleverly. The designer drug problem may become an international problem, and a single gram of any very potent drug could be synthesised in one location, transported to distribution sites worldwide, and then formulated into many thousand, perhaps 1 million doses." So quite prophetic, I think, that Mr. Henderson predicted this back in 1988, and it just shows how important our monitoring approaches are here in Australia in order to detect these emerging drugs. I just want to acknowledge some of my very clever collaborators and students. So Jenn Smith and Courtney Webber over in WA, Rebecca Surjana, my PhD student, who's done quite a lot of this work, Lockie Scully, Catherine Izawadi, some other members of the EDNA team, and of course all the EDNA and EDNAV site investigators. And thank you very much for your attention.